what we need physicians across the board to understand is you can still intervene. You don't have to wait for your hospital legal system, the legal system within your hospital to tell you for this woman with, who's got pre-viable rupture of membranes and she's infected, you can intervene immediately. This is Caring for Both, a curbside consult series by AAPLOG. On this podcast, we bring on experts to provide insights that can help you as a medical professional in your life-affirming practice and career. We release new episodes every Thursday. I'm your host for today, Dr. Christina Francis, CEO of AAPLOG, and also coming to you from our national conference, the Matthew Bulfin Educational Conference. And I'm so happy to have with me today Monica Snyder, the Executive Director of ProLife advocacy organization, Secular ProLife. This is going to be a reverse interview which is really fun. So Monica is going to be asking me some questions coming from the patient perspective, as well as what maybe non-medical pro-lifers want to know about life-affirming medicine. So, but my one question that I'm going to get in is, Monica, can you tell us a little bit about yourself and maybe what got you into this work?
Sure. Well, like Dr. Francis said, I'm Monica Snyder. I'm the Executive Director of Secular ProLife. And I am an atheist, and Secular Pro-Life, our main goal is to advance secular arguments against abortion, but also make space for what we call non-traditional pro-life people to do anti-abortion work. I got into this by arguing online. I joined Facebook, and I was arguing about abortion, and I met this woman, Kelsey Hazard, and a year or two later, she contacted me. She knew I was secular, and she said, I want to make this organization. Do you want to help? And at the time, I thought it would just be arguing online, which a lot of it is. But it's really ballooned since then, so that's how I ended up here.
Yeah. Well, if any of you follow Secular Pro-Life on social media, you'll know that Monica and her team do such a great job making really strong arguments to support the life position. And before we get into letting Monica ask me her questions, I just have to say that it really brings joy to my heart that you and I are sitting here doing this, because I think this is what we have lost so much in this country, is the ability for people who are coming from different backgrounds. I'm an evangelical and Monica's an atheist, and but we may disagree about some things, but we agree about this and can sit down and have a great conversation. And I consider Monica a friend, and we can have wonderful conversations. So like I said, it really just brings me joy, and I really hope that we can have more of these kinds of conversations.
Absolutely. And of course, in-person conversations, I find, with people that have different religious beliefs, but also with people who view abortion differently, tend to go much better than online. And I just wanted to emphasize that, because we are very online. And I do believe in arguing online under certain circumstances, but just remember, when you're arguing online, that's a specific subset. Yeah. Talking in person with people you already have relationships with is a different thing, and it's often more doable than people think.
Absolutely.
That said, I did ask Secular Pro-Life's followers, I said, I'm going to be interviewing Dr. Christina Francis. What would you like to ask her? And they gave me way more questions than we will be able to cover today. But easily, the most common questions were related to, in a post-Dobbs era, we have all these different abortion restrictions, abortion bans, so forth. And our followers and the American public keep hearing this drumbeat of stories about women saying they were unable to access life-saving care. So the first question I have really is, are any of these stories true? And then the second question I have is, why would this be happening? The laws are supposed to incorporate life-saving exceptions. I don't know any pro-lifers who think that a woman, if she's in an emergency, should not be able to access care. That's not what we're about. So can you talk more about what's going on with that?
Yeah, absolutely. Well, I think I was maybe a little bit prepared for this to happen after Dobbs, but I was definitely not prepared for, as far as hearing this narrative. And I think part of the reason why I wasn't really prepared was because I've practiced my entire career from a life-affirming standpoint, and I've never let a woman die in front of me. And it wasn't because I had a law at the time under Roe that allowed me to do abortions. It was because, if we go back to kind of basic pro-life apologetics, the intent of an abortion is to end the life of that fetal human being. and that's not the intent when we intervene to save a woman's life. But I think for many physicians who maybe haven't actually thought about this, now they're being forced to think about it. And,
Right.
you know, under Roe, they didn't really have to think about it. And now they're having to think about it. And I really think a lot of physicians are kind of second guessing themselves. I also think that there are bodies that were meant to explain these things to physicians.
Explain bodies.
Sorry. Yes. Like medical organizations like the American College of OB-GYNs, or even state hospital associations, or, you know, state medical boards, things like that, that should have been clarifying these new laws to their physicians and helping physicians understand that they can still every time intervene when a woman is facing a life-threatening complication of her pregnancy without penalty from the law. So I think that's part of it, is that we have physicians who all of a sudden are facing, in some states, potentially criminal penalties if they break the law. And so, you know, I think it's important for us not to demonize many of these physicians who are legitimately scared, but it's because they don't really understand. You know, I'm a physician who goes to my state house often, and I work with, I go to, you know, the Hill in DC, and, you know, I work sometimes in that legislative space, so I read bills. Most physicians don't read bills. So to expect them to take bill language and incorporate that, you know, directly into their practice, that's just not something that most physicians are used to doing.
But to take it away from the physicians for a second, I've been reading about how physicians will be, you know, they'll feel confused. They're not sure what these new regulations mean. So they will go to their hospital administration or legal team and say, can you give us guidance? And they're saying that the teams are not giving them guidance. Some of them are claiming that the teams are saying, just call us on a case-by-case basis when they only work 9 to 5 on weekdays.
Right.
What is that about? Why would they not give guidance?
Right. Well, I mean, really, that's where the malpractice is happening. I mean, this is not appropriate. Physicians need to be able to make timely decisions in order that women can be taken care of.
Right.
And it's being painted that it's the fault of the laws that physicians aren't. But as you said, oftentimes it's the fault either of hospital administrators or the hospital lawyers. Not bashing all lawyers, but we all know, you know, that hospital lawyer's job is to protect the hospital
rather than the patients.
You know, and so, and they're not the ones there taking care of women. And so I think what we need physicians across the board, and this is something that AAPLOG is actively working on, what we need physicians across the board to understand is you can still intervene. You don't have to wait for your hospital legal system, you know, the legal system within your hospital to tell you, for this woman with, you know, who's got pre-viable rupture of membranes and she's infected, you can intervene immediately. As just one example, you know, you don't have to wait until she's septic and almost dying before you can intervene. We all, and really, you know, who we need to look to understand how we do that is those of us who have practiced life-affirming medicine our entire careers. We know when to make that call, how to make that decision, because we have to get to that point ourselves where we feel comfortable intervening, but also we take care of a lot of patients who may want expectant management in certain situations, and then being able to tell them when we should intervene.
I want to be extremely clear on one point here and get your feedback on this. So we hear people say on the pro-life side, abortion is never medically necessary to save a woman's life. And sometimes I think that both pro-choice and pro-life people hear that, and they think that means that pro-life physicians will never intervene if it's going to have the foreseeable result of the death of the baby. Can you comment on that?
Absolutely. So, you know, intent is extremely important when we're talking about anything we do in medicine, actually. I've often used the analogy of, you know, if I make an incision with a very sharp knife on a woman's abdomen because her baby is in distress and I need to get her baby out quickly, that's a C-section. And I'm doing that for her baby's benefit.
Right.
If I do the same thing just because I'm angry with the woman, I mean, it seems ridiculous.
I know.
It seems totally ridiculous, but you know, it gets at the point of intent that, because I think sometimes people think that we're only focusing on this word intent in the situation of abortion, but it's not, you know, I mean, if I did that same surgical procedure, but with the intent of harming that woman, that's assault, and I can go to jail for that, as I should. So, so intent actually comes into play in many aspects of medicine. And so, and those of us, again, who do not perform induced abortion, and I think, again, we need to be very careful with how we understand this wording.
Clearly.
Induced abortion, its sole intent is to end the life of that fetal human being. That, with that intent, That is never medically necessary. However, there are times when we need to do what we refer to as a maternal fetal separation, meaning mom is facing a life-threatening complication, whether that be an ectopic pregnancy, which is clearly not an abortion, or whether it be, she has previable rupture membranes and she's starting to become infected.
Right.
But the way I know that most physicians, if they can take a step out of this highly charged, highly politicized environment, they know that that's not an abortion. And I know this because I've seen partners of mine who are pro-abortion. I mean, they think abortion is a good thing.
Sure.
But who go into a patient's room who's in that situation where her membranes are ruptured. She wanted expectant management, but now she's getting infected and we don't have a choice. We have to intervene.
Right.
They go in, they sit down with her, and they don't say, I'm really sorry, we need to do an abortion.
Right.
They say exactly what I say. I'm really sorry, but we need to get you delivered.
Right.
And so, I think they understand that that's a distinction. It's very different to deliver mom an intact baby that she can hold and she can grieve if the baby doesn't survive. Mm-hmm. The other thing I'll tell you from one personal experience that I had was we had a mom who, I think it was just preterm labor, but we, based on our ultrasound scans, thought baby was a certain number of weeks along in the pregnancy.
Right.
And it was going to be before the point of viability, before our hospital could intervene to really support that baby. When that baby was born, that baby was bigger than we were expecting.
Wow.
Now, thank goodness I work at a facility where we have a NICU,
right,
who's right there. And so we called our NICU. They came right down and they were able to
gosh.
at least start interventions on the baby. Now, the baby didn't end up surviving. I mean, he was, right on that cutoff, but still there was that opportunity.
Yeah.
And had he, responded a little better to those interventions, maybe he would have survived. So, but had mom gone through a destructive procedure, which is what most abortions are, we would have never even had that opportunity.
Right.
And I just think, how many times does that happen where we do these destructive procedures and then we don't leave the option of helping baby potentially if we can, but even if not, we know that the grieving process is so much better for the family if they have a child that they can hold and grieve. And then even if that's the foreseen consequence, it's not our intended consequence.
Now, I'm going to veer a little bit away from medicine into philosophy, which I'm told you are quite good at. So I'm okay at it. But putting on sort of the pro-choice hat here, counterpoint.
Yeah.
What I hear sometimes when we talk about, you defined abortion as with the sole intent of the destruction of the child. Mm-hmm. Some pro-choice people will counter that the purpose of abortion is not the destruction of the child, but it is to end a pregnancy when you don't want someone else to use your body or something like that. And so they think that, they will tell me, I've had these arguments, that abortion is just termination of pregnancy, destruction of the child doesn't have to be part of it, and that's why they claim incorrectly that after viability, you would just induce live birth. And we know after viability that's not what abortion is. Right. But backing up, they believe that's what's happening. And so they believe in the first trimester, the death is incidental because the child's not developed enough, but that wasn't the goal. What do you say to that?
Well, I think there's a couple ways to respond to that. First is if you define abortion in that way, then technically a C-section at term is an abortion. Delivery at term is an abortion because you're ending a pregnancy. And,
right.
I think, again, it
it's
sounds a little
kind of
ridiculous,
silly. Yeah.
but that's sort of the natural, logical conclusion of that argument. The second thing is that when we are talking about intervening, in the case of infection and PPROM, there's a medical reason why we have to intervene.
Right.
For a first trimester, even, abortion where mom doesn't want the baby utilizing her body as you referred to.
Right.
There is no medical reason why that pregnancy needs to be ended. And so, I think there's a couple distinctions there for sure.
I think that's extremely important. So backing up a little bit, you were explaining that you do intervene as a pro-life physician. You will do interventions when the mother's life is threatened, even with the foreseeable death of the baby. And I just wanted to say that again so that people understand. When people say abortion is never necessary for the mother's life, they don't mean we don't intervene to help the mother.
Exactly.
They mean that's not how we are defining abortion. And it's a different conversation. Right. So kind of changing tracks a little bit.
Yeah.
Related to the life-saving care, we hear a lot of stories of women claiming they couldn't get care for miscarriage management. Mm-hmm. And some of those stories, I've seen people say, the child already passed away and they will not intervene because it's against the law. And some of those stories, it's not that the child has passed away yet, but there's a you referenced some of the possible situations.
Yeah.
Can you talk a little bit more about why we are hearing these stories? What is going on with that?
Yeah. Well, part of why we're hearing these stories, honestly, is because the medical nomenclature, the wording that we use in medicine surrounding pregnancy loss is actually very vague. And prior to Dobbs, actually, groups like AAPLOG were even talking about this language is so vague, we should get rid of it, actually, because we don't actually know what these terms mean. Using the word abortion for a pregnancy that ends prior to 20 weeks is about 100 years old. It comes from before we had ultrasound to understand why a pregnancy was lost. And so there was just this general term. So first things first, no state outlaws any kind of procedure or treatment when a baby has already passed away and needs to be evacuated from the uterus. So we need to understand procedures are not outlawed. Procedures with certain intent might be outlawed. For instance, a DNC for a miscarriage where the baby's already passed away, not outlawed. A DNC to end the life of a preborn child who is living and healthy may be outlawed. And so I think we need to understand that. The other thing is that even in a situation where that baby is still alive, if the mother is facing significant hemorrhage, which some people might call a threatened abortion, threatened miscarriage, or an inevitable miscarriage,
many options.
Exactly. We have the ability to intervene in that situation. That is not prevented by the law. But again, I think that it is a misunderstanding or perhaps wanting to use those terms to justify a purely elective induced abortion.
We've seen more and more in the circles I run in, people from the other side saying that miscarriage is an abortion, like a spontaneous abortion, induced abortion, and we have to push back and like, okay, well, why are there different adjectives? Can we explore that a little bit? But that's really good clarification. So we do hear stories. The other thing I wanted to point out is we hear stories sometimes of people not getting appropriate care in states that don't have any abortion limits. And we hear stories of people getting appropriate care in states that do. So I feel like there's a selection bias here in what gets covered and what doesn't. But maybe even going into that, for example, Secular ProLife did a blog post on a woman who, I think it was an ectopic pregnancy, was not handled appropriately, and it became an emergency in New York. So why do these things ever happen? Especially in a state where there's no abortion limits, why do we still see sometimes where people are not getting appropriate care? This is like a broader question about medicine.
Well, but I do actually think that it addresses what we're seeing, though, with some of these stories of women who come in with ruptured membranes and they're told, well, we can't do an abortion here, so go out to the parking lot and wait until you're almost dead before you come back. It's the same general principle that's underlying all of this. And, part of it, honestly, is this could be an hour-long podcast in and of itself. But many of the demands that are placed on medical professionals, physicians especially right now, I think are leading to some level of burnout, as well as some of the ways, honestly, that we practice medicine in the U.S. right now have led to this disconnect between physician and patient, where physicians are relying oftentimes on maybe lab studies or imaging studies or, things like that, without actually putting hands on the patient, spending time with the patient, doing a thorough history and physical. And I see it all the time, Now, sometimes patients present in really atypical ways. And anybody's going to miss the diagnosis. That's certainly possible. But I also just see in general, in my practice and the practice of colleagues, friends, that, I just don't think that we in general are spending enough time with our patients. And I do think that can lead to inadequate care at times. Also, if a physician is being forced to see too many patients by sort of the bureaucracy that they're managed by, that can lead to errors as well, because you're having to move through patients so quickly. So there's all kinds of factors that play into that. But, I think ultimately what it comes down to is that we need to go back to respecting that physician-patient relationship. If we do that, we certainly don't see that within the abortion industry. They don't respect that physician-patient relationship whatsoever. There is no relationship. But we need to get back to that and understanding that we have full freedom in any state in this country right now to take excellent care of both of our patients, both our maternal patient and our fetal patient. Thankfully, most times we can take care of both of them, maximize both of their health. there are those times where we can't do that. And in that case, as you and I know are both in strong agreement on, that we are pro-life in all circumstances, meaning we are pro-life of the mom and we are pro-life of the baby. Sometimes we can only save one of them, and that's absolutely what we need to do. And as you said, I don't know a single pro-life physician who has ever sat and watched a woman die because they had a moral objection to performing some, indicated procedure, whether that be a C-section or, vaginal delivery, something like that. So, again, I think we need to sort of calm down the politicized environment a little bit and really talk about what,
That's a nice thought.
yeah, but really talk about what, life-affirming medicine actually looks like. And I think if some of our colleagues who maybe haven't, again, had to think about that in the past would realize there are tens of thousands of us across the country who practice life-affirming medicine. We know how to take good care of patients. Then I think, there could be real advancement in women's healthcare, regardless of the state that someone's practicing in.
Last question for now. Have you had patients who sought you out specifically because they knew you were pro-life and they wanted that value reflected in their care?
Yes. Short answer is yes. So, and that's what I try to tell a lot of physicians. And if we have physicians listening to this, I'd even encourage you to join and be on our directory, because I saw my practice increase the more I was sort of out there and vocal about my pro-life stance. And we certainly have a lot of patients that are looking for
So
that.
more on the patient side and on the social media side, we've talked about this before, where we see people say, if you're against abortion, you have no business being in medicine, et cetera, et cetera. And physicians have their own answers to that. But on the patient side, it's like, excuse me, did you know that I, as a pro-life woman, if I'm pregnant, I would like my physician to recognize my child as my child.
Absolutely.
And that means that I'm going to want a pro-life physician. So, you're pro-choice, right? My choice is to have a pro-life physician.
That's right. That's right. Absolutely. Absolutely. Well, I think we have to wrap this episode up. We'll be back together, though, for at least one more episode. So, Monica, thank you so much for being here. Thank you for showing how people who come from different backgrounds can have great conversations about even contentious topics. And thank you to our audience for being with us. We invite you to like the podcast, subscribe. Please leave us a great review, and we will see you next week.